So this is your first case. We are starting with the case, not I'm not starting with the theory part first. Let me give you the case you should think of, okay? And you'll give me the answer, whatever I ask. Okay? Case 1, a 50-year-old male presented in surgery emergency with a 2-week history of crampy pain in the abdomen associated with abdominal distension, fever, bloody diarrhea with mucus, and anorexia for 2 weeks. Initially, the pain was localized in the right lower quadrant, gradually progressed to involve the whole of the abdomen. The pain is not relieving on medication. Okay? The pain is associated with fever, which was documented 101 degrees Fahrenheit, associated with abdominal distension, bloody diarrhea, the frequency of which was 5 to 6 times per day, loss of weight, anorexia, all were there. No such episode in the past was noted. Patient is a non-alcoholic. Family history is not significant on examination. Okay. So first, on the basis of history, what all is coming to your mind? Matlab, what all you can think of? Just answer. Matlab, anything. Start answering. Write in the chat box. Good. More answers. Infectious dysentery. Good. Acute appendicitis. Very good. Carcinoids, tumor, cyst, lymphoma, IBD. Good, good. Obstruction. Very good. So, what all you? So first diagnosis, acute appendicitis. Very good. Whoever जिसने भी ये सोचा है, it's मतलब the person is quite aware of the clinical background, okay, of appendicitis and obstruction also. So what all we see in acute appendicitis? Just answer. Adenocarcinoma, someone brought TDS adenocarcinoma, directly adenocarcinoma. Don't you think this is an acute condition? अपेंडिसाइटिस में क्या क्या दिखता है? अच्छा चलो छोड़ो, जस्ट टेल मी कि इनिशियली पेन अपेंडिसाइटिस में कहाँ होता है? Where is it located initially? Good, good. Periumbilical, then to McBurney's point. Very good. And yeah, good. Periumbilical pain. Then it radiates to which side? Right lower quadrant, na? Yeah. McBurney's point is the most tenderness at that point is quite characteristic of acute appendicitis, right? Then pain. Then what are the signs you see in appendicitis? Signs, on examination, what are the findings you will see? McBurney sign, yes. On examination, basic finding. Tenderness at McBurney's point is good. Besides that, Swas sign, good, very good. Okay. Then, chalo, we move ahead. On examination, the patient was conscious oriented. The fever was, temperature was 100.5 degrees Fahrenheit. Pulse rate 115 beats per minute. Respiratory rate 28 per minute. BP 118 by 80 millimeter of mercury. Per abdo Abdomen was distended with diffuse tenderness, guarding, and rigidity. Per rectum was empty. Examining finger was tinged with blood and mucus. CVS S1, S2 present, respiratory bilateral air entry equal, CNS within normal limits. And on lab findings, increased RBC, increased WBC or CRP. Now, what is your diagnosis on the basis of this? Clinical, all clinical. Yeah, but pay attention to this part. Abdomen was distended with diffuse tenderness, guarding, rigidity. What can you think of? Basic. सबसे पहले तो सर्जरी में यही सीखते हैं ना. Acute appendicitis का case is so common, and you should also know the complications of appendicitis. Or anything, guarding, rigidity is there. Anybody who can answer? I can't see many answers. Guys, please answer. अच्छा ये बताओ कि डिस्टेंशन है, टेंडरनेस है, डिफ्यूज टेंडरनेस, गार्डिंग रिजिडिटी. What can you think of? Anything which comes to your mind. Doesn't matter if it is right or wrong. Anything. I can't get the answers. You guys used to answer so much na, during offline classes. Rupture of appendix. Very good. Perforation is one of the most common complication of appendix. Okay. So in perforation because of any cause, be it intestinal obstruction, be it diverticulitis, be it anything, any cause, because you will see that abdomen is distended, diffuse tenderness is there, guarding rigidity. On the basis of that only you can in surgery now we usually think of perforation. Always think of perforation. Okay. So differentials are acute appendicitis. I have explained completely. Intestinal obstruction because of any cause, adhesions, growth, hernias, anything. Growth, colon cancer, like, okay, and adhesions हो गया, stricture हो गया, and all this and many other causes like anything which is obstructing the lumen. And intestinal obstruction का भी one of the complication is perforation peritonitis, and which will lead to these sign and symptoms, and which will lead to this kind of presentation. Okay. Then inflammatory bowel disease. Yes, but that won't create such an acute condition. Not much. We'll discuss in subsequent slides. Acute diverticulitis. Yes, it presents with these signs and symptoms with this condition, and acute the diverticulum, which is formed is formed in large bowel, and it can lead to perforation, ultimately leading to perforation peritonitis. Renal colic ka pain, not that severe, okay, but yes, it is there in the right lower quadrant. It may be present there. Amoebic colitis or any other infectious etiology we can think of, but not that severe. Okay, amoebic colitis we'll see in the subsequent slides. Okay, if it can create such a condition or not. Okay, then we did further investigations, and on colonoscopy we found multiple ulcerative lesions with surrounding inflammation in the rectum, ascending colon, and cecum, with the mass located in the cecum. Okay, multiple ulcerative lesions. Just keep that in mind. Okay, with a mass located in the cecum. Then this is the mass. Can you think? Can you see? This is such a big mass in the cecum. On X-ray chest, patient reveal air under the right dome of diaphragm. So, air under the right dome of diaphragm. Diagnosis. Diagnosis. Just write few answers, na? Empty chat box. Air under the right dome of diaphragm on erect chest X-ray. Good intestinal rupture. तो परफोरेशन पेरिटोनाइटिस का डायग्नोसिस हो गया. ओके. Then on CT abdomen, we did further investigations. On CT abdomen, a phlegmonous mass adjacent to the cecum, along with multiple ill-defined hypoechoic hepatic lesions were present. Okay. Then we are moving ahead. So there is a mass located in the cecum. There is multiple ulcerative lesions present in the whole of the colon, and along with on CT we could see some hepatic lesions. Okay, keep that in mind. Okay, the patient underwent a laparotomy where a perforated cecal mass with peritonitis was found, and a subtotal colectomy with an ileostomy was performed. The patient required serial drainage of hepatic abscesses. Ultimately, was given intravenous metronidazole and prolonged oral paromomycin. On biopsy, serosa was covered on cross. When we got the specimen of colectomy, we could on cross when we were doing the crossing of that specimen, we could see serosa was covered with exudates. It was thickened and showed numerous perforations. So perforation tha, peritonitis tha, that we could see on the basis of clinical and history and clinical examination. On cutting open of the specimen, numerous ulcers with surrounding inflammation was present in the cecum and ascending colon. A mass is located in the cecum, approximately 5 into 4 centimeter in size, with thickened wall. Okay. So this is a perforation, as you can see. Okay, this is a specimen taken from a museum. The picture is taken from a museum, and these are multiple ulcerative lesions in the colonic mucosa. Okay. And this is a perforation. Okay, and this is all mucosa is completely ulcerated. Because normally you see these folds, no? But it is all ulcerated. On microscopy, microscopic examination revealed numerous flask-shaped ulcers in colonic mucosa reaching up to the submucosa. At least there were transmural ulcerations. Ulcers were covered with necrotic debris with misinflammatory infiltrate. In necrotic debris, numerous trophozoites of Entamoeba histolytica seen, which were PAS positive. PAS is a stain, special stain done routinely. Okay, so I'm saying that these flask-shaped ulcers there is inflammation around it, and sometimes mainly these were limited to mucosa and submucosa, but there were few transmural ulcerations were also there. These and in the necrotic debris of the ulcer, you could see Entamoeba histolytica trophozoites, which were PAS positive. Biopsy from the mass. Okay, there was a cecal mass, no, you know. Biopsy from mass show granulation tissue with peripheral fibrosis with core of dense inflammation along with numerous trophozoites of Entamoeba. So Amoebic colitis diagnosis बन किया. Anything else besides amoebic colitis? I you got मतलब you know कि it's amoebic colitis, but the diagnosis should be including something else also. Okay. Any complication you know of amoebic colitis? Any complication? You know amoebic colitis का कोई complication which is creating such an acute condition? Answers. Hmm? Tell me. I thought this is an intelligent batch. एक कोई भी एक complication. There is a mass there ना in the cecum, and ulcerative ulcer से you got entamoeba histolytica का trophozoites. Besides that, mass, ulcer, hepatic lesions. Diagnosis तो amoebic colitis का बन गया. Amoebic appendicitis, no, but that's a really good diagnosis. Mass is there. Yeah, maybe liver abscess is there. Maybe colitis is there. One more thing, one more complication. I have covered almost 2 to 3 complications of entamoeba in this case. No, let's see. On microscopy, see these. This is colonic mucosa. Can you all appreciate? And this is pus. So you can see numerous trophozoites of entamoeba histolytica ingesting with RBCs in their lumen. Okay, and these trophozoites are ingesting RBC, and which can be seen here, red dots. I'll show you in the next slide. Okay, and these are all pus positive. This is a pus stain. Okay. And these are all these are all present on the colonic mucosa. This is colonic mucosa. Okay, these trophozoites are attached to the mucous layer of colonic mucosa. Sort of attached. Is sort of attached. Can you see this is entamoeba trophozoite, and can you see this is your RBC. This is your central keratome of entamoeba histolytica. This is making some pseudopodia. Okay. So it has ingested RBCs. So in the previous slide, you are seeing it's not that big, but some red dots are there. So which are RBCs, which are ingested by trophozoites. So diagnosis is amoebic colitis with amoeboma of cecum with amoebic liver abscess complicated by perforation. I know it's a bit difficult, but I have covered almost 2-3 complications of entamoeba. Amoebic colitis is normal. Amoeboma is one complication. Amoebic liver abscess is one complication, and perforation is there. Okay. And this acute condition can be termed as permanent acute amoebic colitis. So, entamoeba histolytica, some general points regarding the parasite. It is an anaerobic parasitic amoebozoan estimated to infect about 35 to 50 million people worldwide. Family is Entamoebidae and genus is Entamoeba. The active trophozoite stage exists only in the host and fresh loose stool. The trophozoite stage exists only in the host and in the fresh stools. Okay. Cysts survive outside the host in water, soil, on foods, especially in the moist conditions. The cysts are readily killed by heat and by freezing temperatures and survive only a few months outside the host. Okay. So, can you all tell me which is the infective stage of entamoeba and which is the pathogenic stage? It exists in two forms, trophozoite and cyst. So, which is the infective stage, which is infecting the human, and which is the pathogenic, which is causing the pathogenesis? Batao, start answering. Cyst is infective and pathogenic. Which is the pathogenic stage? Okay, good. Very good. Cyst is infective and trophozoite is pathogenic. Let's see in the next slide. Okay. So the infective stage is a quadrinucleate cyst, which is the mature cyst. Because immature cyst consists only one nucleus. Okay. Then mature cyst consists four nucleus. Okay. The definitive host is human because we are fond of eating bahar ka food, street food. Okay, mode of transmission, ingestion of mature cyst through contaminated food or water. Pathogenic stage is trophozoite. You have already told me. Good. And the most common sites are is Zika, followed by right colon, rectum, sigmoid, appendix. Motility is active, progressive, and directional. Nucleus shows string and dot appearance because there is a central karyosome and the chromatin is located peripherally. Okay. Mode of reproduction is by binary fission. Got it? Yes. So this is the life cycle of entamoeba. You are ingesting mature cyst containing four nucleus. Okay. You will be able to understand. Okay. You will learn in macro also, but let me briefly describe it to you. Okay, mature cyst has four nucleus. Four nucleus existation occurs inside the human because it colonizes our large bowel. Okay, basically comes down till here, and it colonizes the large bowel, and their existation occurs. Okay, each then trophozoites are released containing one nucleus. Okay, so mature cyst, one cyst is giving rise to four trophozoites, which in turn divide by binary fission, giving rise to 8 trophozoites, which invade the intestinal mucosa. Okay, and invasive infection occurs when it enters through the bloodstream and enter liver, brain, or lungs. Okay, so there is one cyst which is giving rise to trophozoites, initially four trophozoites, which divide by binary fission and giving rise to 8 trophozoites. Okay, which in suppose there is ulcer, they are forming ulcers. So perforation hua, they can invade through the blood vessels and they reach various sites. Okay, like liver, brain, or lungs. Sometimes these trophozoites ancestation, they are making cyst again. So ancestation occurs, mature cyst is formed, then which has one nucleus. Okay, then it forms quadrinucleate cyst. Maturation occurs, and then this cyst exists in the host. Okay. So did you get this slide? Are you able to understand this life cycle? Should I move on? Okay. Then this is a simple slide. Trophozoites are there in the colon. These are passed in feces. Taken. They initially form cyst 1 to 4 nuclei. Ancestation, which I am saying. Okay. Ancestation occurs. Cysts are passed in feces. They contaminate the food and water. Thus, these cysts are ingested. and from this small bowel they enter the large bowel and they make trophozoites, which again this cycle goes on and on. Okay. Then sign and symptoms, they are general signs. Like most of the cases they are asymptomatic. Uh, Few cases have abdominal dysentery, fever, abdominal pain, nausea, vomiting, loss of appetite, weight loss, fatigue. Okay, these are vague signs and symptoms. Okay, pathogenesis. Pathogenesis. These trophozoites are existed in the terminal ileum region. They colonize the large bowel, remaining on the surface of mucus layer, feeding on the bacteria and food particles. Trophozoites move through the mucus layer where they come in contact with the epithelial cell layer. Okay. Entamoeba histolytica has a lectin that binds to galactose and N-acetyl galactosamine sugars on the surface of epithelial cells. The parasite has several enzymes such as pore-forming proteins, lipases, cysteine proteases, cause lysis of the epithelial cells by inducing cellular necrosis and apoptosis. Enzyme released allow penetration into intestinal wall and blood vessels, sometimes on the liver and onto the liver and other organs like the brain, lungs. The trophozoites will then ingest these dead cells. So I think the important point is this. Entamoeba histolytica attaches to the colonic mucosa through through the lectin receptors that binds to the galactose or N-acetyl galactosamine sugars present on the surface of epithelial cells. Okay, and these also help various enzymes like pore-forming proteins, lipases, cysteine proteases, which cause lysis of epithelial cells by inducing cellular necrosis and apoptosis. Okay, let's proceed further. This damage to the epithelial cell layer attracts human immune cells, which in turn can be lysed by the trophozoite. These in turn can be lysed by the trophozoite, which releases immune cells on lytic enzymes into the surrounding tissue. So, the enzymes of its own, okay, the enzymes of entamoeba and enzymes of these human immune cells, which gets attracted to this site, and the enzymes of both these uh, entamoeba and immune cells, they cause the destruction and they create the ulcer. Okay, this destruction manifests in the form of ulcer in the tissue, which is typically described as next slide. What is this? Answers. What can you see? What is this? Can somebody tell me what is this? Hello? Hello? Since nobody is answering, this is flask-shaped ulcers. This is flask-shaped ulcer, which is formed by the lytic enzymes of immune cells and the enzymes of Entamoeba histolytica itself. It is limited to mucosa and submucosa. Okay, it is not extending till here. When it extends, it can cause rupture, and the liver these trophozoites can enter the bloodstream and then can go to the other organs like liver, lung. brain, etc. Okay. What is this? It's written, but where do we see it? Where do we see it? Anybody who can answer? किसमें दिखता है? छोड़ो. It is seen in amoebic liver abscess. क्यों मिलता है? हेलो, क्यों मिलता है? छोड़ो. बताओ भाई, कोई भी बता दो. Anybody who can answer? अच्छा, इसमें होता क्या है ये तो बता दो. बस degraded RBCs. Good. So diagnosis कैसे करते हैं? Diagnose it is. अच्छा, कोई भी dysentery का पेशेंट है, उसका हम सबसे पहले क्या लेते हैं? माइक्रो में भेजते हैं. दिख रहा है, सामने ही है. गुड. स्टूल सैंपल. ओके. सो स्टूल सैंपल लिया, ठीक है, उससे हमने स्मेयर बनाया, which is known as direct fecal smear. Or we can take smears of aspirates or scrapings obtained by proctoscopy or the aspirates of liver abscess. Okay. So what will we see? This is entamoeba histolytica का cyst, quadrinucleate cyst. There are 4 cysts. Okay, 4 nucleus. Sorry. ठीक है. And this is trophozoite. Trophozoite which has RBC. You all have seen in the previous slide also. And this is central karyosome. On the basis of this, the diagnosis of entamoeba is made. Okay. Then let's move ahead. Then these are the other investigations which should be done. Okay, PCR, polymerase chain reaction for species identification. Sometimes only the use of a fixative is effective enough in detecting cysts. Culture from fecal samples. These media are used, Robinson and Jones medium. Enzyme immunoassay, indirect hemagglutination. These you will read in macro. Then antigen and anti-amoebic antibodies detection in serum. In which conditions will you see? Basically, these are more common in liver abscess. The antibodies are formed because the trophozoite has entered the bloodstream, na? So it will make anti-amoebic antibodies, and these can be detected in the serum, and diagnosis can be made, especially in liver abscess. Tissue biopsy, I have already described the gross and microscopic appearance. Cyst aspiration in case of liver abscess. Okay. Complications, amoebic liver abscess. In this case, there was amoebic liver abscess was there. Amoebic lung abscess can be there, which will there will be a liver colored sputum will be there. Or empyema can occur. Empyema कोई बताएगा? Anybody? What is empyema? Empyema, amoeba formation, okay, and fulminant amoebic colitis. These 3 conditions we have discussed in this case. It's a hypothetical situation because all these complications at a time are very rare to occur. It can be there, but not in all cases that you'll see amoebic liver abscess also, amoeba also, and fulminant amoebic colitis also. Okay? And perforation peritonitis. Intussusception can occur. It's one of the rare complications. of amoebic colitis. It is seen usually in young children. Okay. इंटरसेप्शन में क्या होता है बताओ? Anybody? Last class में हुआ था ना, डॉक्टर अनुभूति took the class of intersection. So, then stricture formation can occur. Toxic megacolon, yeah, a part of ball telescopes into the another part. Good. And most common site is, which is the most common site of intersection? It basically occurs in children. Yes, ileocecal. And the classical, it is asked in NEET PG also. The stool which is formed in, it has very red colored jelly kind of stool, like very reddish, chipka stool. Okay. Yeah, good. Somebody wrong. Stricture formation is very rare to occur, and another complication, toxic megacolon, is very rare. You should intersection, toxic megacolon, or you will read in surgery. Okay. Let's go ahead. Treatment is done. Intestinal infection, usually metronidazole derivatives such as metronidazole is effective enough against the trophozoite form of amoeba. Since they have little effect on amoeba cyst, usually this treatment is followed by an agent like paramomycin or diloxanide furoate that acts on the organism in the liver. Okay. In cases of liver abscess, since it is the organism is targeting the solid tissue, the drugs like metronidazole and chloroquine are not besides the surgical drainage. It should be given following the aspiration. You should give medical treatment also. Okay. Treatment of liver abscess must include agents that act in the lumen of intestine to avoid re-invasion. Okay. Then people without symptoms, paramomycin and other treatments such as diloxanide, furoate and idoquinol, these can be used. Diloxanide furoate can also be used by mildly symptomatic people who are just passing cyst. They have no symptoms because majority of people don't have any symptoms because it's in most of the cases it is asymptomatic. Only in immunosuppressed cases you will see such acute conditions, such complications. Okay. Case 2. So amoebic colitis is done. So I am starting with next case 2. A 22-year-old female who presented to the surgery department of a tertiary level hospital, having been referred from a private clinic with a 2-month history of severe abdominal cramps, persistent bloody and mucoid diarrhea, weight loss and tiredness. 2 months ago, symptoms began with abdominal cramps and an intense urge to pass stool after every meal. Her symptoms rapidly worsened with passage of time, becoming more frequent. Within 2 days, she was passing persistently watery diarrhea mixed with the fresh blood and mucus. She was seen by her general practitioner who treated her for gastritis. Okay. This much understood. Okay. The patient is having these symptoms and the practitioner treated her for gastritis. Okay. Then 1 week later, she collapsed at home and was admitted to the hospital for investigation. She was discharged 2 days later without a diagnosis. Then 1 month ago, again the symptoms started. Symptoms persisted and she experienced diarrhea and vomiting after eating or drinking, which lasted for 10 days. She was admitted to the hospital for rehydration and further investigations. No conclusive diagnosis was made. Again, the diagnosis couldn't be made. Currently, the patient is passing 10 to 20 liquid stools per day. Diarrhea is mucoid and bloody. Occurs day and night. Patient complains of malaise, lethargy, anorexia. The patient has lost 8 kg in the past 2 months. There is no past surgical history, no significant medical history. Mother only family history may her mother had type 2 diabetes. No other chronic illness in the family, no known allergies. What all can you think of? Mhm. Answers? Any diagnosis which you can think of? बार बार symptoms हो रहे हैं. No diagnosis could have been made till now. What? Chal, right. Let's start with examination. Then the patient is a thin, ill-looking young woman, conscious, alert, in obvious discomfort. The vitals are temperature 37 degrees Celsius, pulse is 98 beats per minute, respiratory rate 18 per minute, BP is 120 by 70, pale mucous membranes were noted. Abdominal examination, guarding and tenderness in the left iliac fossa and hypogastria. Any diagnosis you can think of. Don't worry, I won't scold you for wrong answers. Just write your answers. Whatever comes to your mind, whatever you can think of, anything, anything. Diagnosis, the practitioner is not able to make any diagnosis, and the patient is presenting again and again. So, if till now there is no diagnosis, let's move ahead. These are the differentials I made for this case. Infectious colitis can be there, but by that time, all the investigations which must have ruled it out if there is any infection or not. Okay, irritable bowel syndrome. Irritable bowel syndrome can present this with this condition because it's very difficult to diagnose irritable bowel syndrome because it's more of a clinical entity. Not there is no pathological abnormality which can be detected. Okay, only the patient will present with the symptoms, these symptoms, vague symptoms, and you will not be able to diagnose IBS because pathology may, you can't see anything. Okay, malabsorption can be there. Okay, celiac disease. Celiac disease का बताओ. What are the antibodies seen in celiac disease? You all must have read something about celiac disease. No, not till now. Chalo. In celiac disease, basically, it's a malabsorption syndrome. You all know this. It presents with these vague symptoms like diarrhea, distension, and failure to thrive. Okay, it is basically a disorder of small intestine. Okay, and it's an autoimmune conditions. That's why I asked, okay, what are the antibodies? Which is commonly asked in NEET PG exam. Very commonly asked. So you all should be aware of these antibodies. I won't tell you now. I'll ask you later. Okay. On biopsy, there is a blunting of villi, hypertrophy of crypts, and lymphocytic infiltration in crypts occur in celiac disease. Okay. So the antibodies you will tell me whenever there is whenever we meet. Okay, in offline class. And the other diagnosis which I made is IBD. IBD and celiac and any other malabsorption syndrome and IBS. These four can be we should think of in this case. Okay. On abdominal X-ray, there is no abnormality detected. Okay. Gastroscopy, upper GI endoscopy, esophagus, gastroesophageal junction were normal. Stomach mucosa was intact and normal. No gastritis, ulceration of blood was noted. Cardia was normal. Pylorus and duodenum was normal. Everything was normal till duodenum. Colonoscopy, very friable mucosa, extensive ulceration with pseudopolyps involving the rectum, entire sigmoid, and left colon up to the transverse colon. Multiple biopsies of the colonic tissue were taken for histological analysis. So, क्या क्या मिला? Ulcerations are there, pseudopolyps are there, colon is involved. Diagnosis, anything, any diagnosis you can think of. Pseudopolyps, ulcers, guys, diagnosis. Chalo, next slide. Biopsy, we got the specimen, we got the biopsy, and on cross, the serosa was uh, appeared. Serosa appeared normal. On cutting open, the mucosa was slightly red and showed extensive broad-based ulcerations involving the rectum, entire sigmoid, and left column up to the transverse column. Polypoidal projections bulging into the lumen were present, and at few places mucosal bridges were seen. This is the specimen we got, okay, and the ulcerations are there because the mucosa is not normal. Uh, I don't know. The ulcers, I can't see very properly, but there are a few projections which you can see here. Okay, this this specimen is kept in museum. You all can see. Okay, there are very few. There are not few. There are small polypoidal projections which can be seen here, and this side is okay, and there were ulcers also. Okay, you can see the specimen in the museum, and you all can appreciate these findings. On microscopy, the pathology is limited to the mucosa and submucosa. Intense infiltration of mucosa and submucosa with neutrophils and crypt abscess was seen. Lamina propria with lymphoid aggregates, plasma cells, mast cells, and eosinophils, and shortening and branching of crypts was seen. So this is the mucosa. Yeah, this is mucosa. Okay, and you can all can see the infiltration in the infiltration of these cells in the mucosa and mucosa. Okay, see this is crypt, and there is lots of infiltration of inflammatory cells in this mucosa. Okay, this is the mucosal lining. Okay, and you all can see the inflammation. And cryptitis is a common feature of which is seen in which condition? Cryptitis, crypt abscess. Okay, seen in which condition? अब तो बता दो, टॉपिक ही है आज का उसका, नहीं पता. See, this is your crypt. Okay, and obtained from pseudopolyp. The biopsy tissue obtained from pseudopolyp shows cryptitis. Here are cryptitis, and no, sorry, this is abscess, and arrow is this is cryptitis. cyst abscess because all the inflammatory cells are in the bone. Okay, the abscess is formed. And this is crypt. This is your crypt. Okay, and inflammation. These crypts occur in which condition? Inflammatory bowel disease, likely ulcerative colitis. So, IBD के बारे में बताते हैं. IBD is a chronic condition resulting from complex interaction between intestinal microbiota and host immunity in genetically predisposed individuals. It consists of these two pathologies, Crohn's disease and ulcerative colitis, frequently present in teens and early 20s, but can develop at any age. More common in Caucasians and in North America, Northern Europe and Australia, but incidence is increasing in Asia and Africa as well because of change in our food habits. The prevalence rate of IBD is approximately 50 per 1 lakh individuals in India. Improved food conditions, food storage conditions, use of preservatives, decreased food contamination, changes in gut microbiome composition affect mucosal immune response. All these will lead in genetically predisposed individuals. These can lead to inflammatory bowel disease. So these are the two subsets of IBD: Crohn's disease, ulcerative colitis. You can see skip lesions. This is see, this is involved, but this is normal. This is involved. Then this is normal. This is involved. This is normal. This is involved. This is normal. This is involved. So these are skip lesions. And on microscopy, you will see the transmural inflammation or ulceration. Okay. In ulcerative colitis, there is a diffuse involvement. Like there are no skip lesions seen, and the involvement will be diffuse. Okay. And basically it involves colitis, colon, and in Crohn's disease, any part of GIT can be involved. In ulcerative colitis, you will see these pseudopolyps, ulcers. So this is a table to differentiate between Crohn's disease and ulcerative colitis. So this table is given in province. You all can see. Okay, the bowel region, mainly any part of GIT can be involved, but mainly ileum and plus minus colon. But in ulcerative colitis, only colon is involved. Distribution, skip lesions are there in Crohn's disease, but in ulcerative colitis, you will see diffuse involvement. The strictures are more common in Crohn's, but are rare in ulcerative. Wall appearance is thick because of transmural involvement. Okay, but it's normal in ulcerative colitis. Microscopic features: in inflammation is transmural here, but it is limited to mucosa or submucosa in ulcerative colitis. Pseudopolyps are more common in ulcerative. Ulcers are deep knife-like in Crohn's and superficial broad-based in ulcerative colitis. Lymphoid reaction more commonly seen in Crohn's. Fibrosis, serositis more in Crohn's. Granulomas, non-caseating granulomas are more common in Crohn's than ulcerative colitis. Fistula sinuses are more common in Crohn's than ulcerative colitis. Why you people are not answering this? I think this was covered by Pooja ma'am, na? In the previous lecture. Okay. Why are you not answering? So let's move on. Clinical features: perianal fistula is more common in Crohn's disease and ulcerative colitis. Malabsorption, fat or vitamins or any malabsorption more common in Crohn's. Malignant potential more in ulcerative colitis, but it is also important in Crohn's disease. Both are pre-neoplastic conditions. Remember that. Both are pre-neoplastic, more in ulcerative colitis. Recurrence after surgery is more common in Crohn's disease than ulcerative colitis. Toxic megacolon more in ulcerative colitis than Crohn's. What are pseudopolyps? Can anybody answer? This is a proper crypt abscess. The abscess which you see in the lumen before, but this is also a crypt abscess, more diagnostic of ulcerative colitis, but in Crohn's disease you will see granulomas. These granuloma which is forming in here, this is colonic mucosa, okay, and this is a granuloma forming. The picture is not very clear, but you all can see if you get to see, if you want to see. There is a non-caseating granuloma. It is asked in NEET PG also in Crohn's disease. But in ulcerative, you will see crypt abscess. You were telling me about pseudopolyps. बताओ pseudopolyps क्या होता है? Anybody who can answer? Anybody who can answer? Pseudopolyps. अभी मैम ने नहीं कवर करवाया. मैम must have told you ना pseudopolyps का. चलो let's move ahead. Pathogenesis. IBD results from a combination of abnormalities in immune regulation, host microbe interactions, and epithelial barrier functions in genetically predisposed individuals. So I have already told you genetically predisposed individuals. These host microbe interactions are altered. Okay, there's changes in the gut flora. So all will lead to the result in IBD. Okay, polymorphisms in note 2. This is commonly asked in NEET PG. Okay, so this is strongest risk gene for Crohn's disease. Just remember that. Okay. So in mucosal immunity, the genes involving HLA molecules or cytokines are more commonly involved. Polymorphisms in genetic loci encoding pro-inflammatory or anti-inflammatory cytokines are involved. Th1 polarization in both Crohn's disease and ulcerative colitis is seen. Th2 activation is more commonly seen in ulcerative colitis. Okay. Also, polymorphisms in interleukin 23 receptor and other molecules involved in Th17 signaling are also involved. Okay. Then, autophagy and cellular stress response. This is given in Robbins. Mutation in genes involved in autophagosome formation such as ATG16L1 and IRGM1. IRGM. These genes are involved in autophagosome formation, and mutations in these genes can lead to formation of IBD. ITG16L1 mutation promotes its degradation, limiting autophagy. Okay, this is linked to Crohn's disease and basically in the pathogenesis of IBD. But very early onset IBD also there, in which the mutations are different from the classic the normal IBDs, because in early onset IBDs there is single genes which are required for epithelial ion transport, immune signaling, or host defense. Any mutation in these single genes can lead to formation early onset IBD. Macrophages producing excessive interleukin 1 beta in infants with interleukin 10 receptor mutations. This is also this is the most common mutation in seen in early onset IBD. Okay. Let's move ahead. So, ulcerative colitis. The diagnosis of that case was ulcerative colitis. You were seeing numerous ulcers, pseudopolyps. Okay. So it's basically involves colon and rectum. Disease of entire colon is known as pancreatitis. Limited distal disease
also referred to as ulcerative proctitis or ulcerative proctosigmoiditis. Backwash ileitis is when there is a mild mucosal inflammation of distal ileum. Basically, it involves colon, but if there is a mild mucosal inflammation of distal ileum is there, in cases of pancolitis, then it is known as backwash ileitis. The symptoms are uh, these vague symptoms like pain, abdominal pain, fever, bloody diarrhea with mucous material, weight loss. Symptoms usually persist for days, weeks, or months before they subside. Any stress, like psychological stress, can lead to this exacerbation of this condition. Okay, so it's the relapsing remitting type of disease. Smoking partially relieves symptoms. So it's not like you are having ulcerative and you start smoking daily. Okay, extraintestinal manifestations. These are usually associated with other autoimmune conditions also, like migratory polyarthritis, sacroiliitis, and ankylosing spondylitis, which HLA is associated with ankylosing spondylitis, very commonly asked in NEET PG. Anybody who can answer? No answer. Then other HLA-B27. Okay, it's associated with ankylosing spondylitis, and it is very commonly asked in your NEET PG. Then other extraintestinal manifestations are uveitis, primary sclerosing cholangitis, other skin lesions. Okay, which is the skin disorder associated with celiac disease, which is commonly seen in associated with celiac. You can say commonly asked in NEET, dermatitis herpetiformis. Okay, chalo, let's move ahead. Cross appearance. You'll see the mucosa is red or granular. The broad-based ulcers are seen, which is usually limited to mucosa or submucosa. There is an abrupt transition between disease and uninvolved colon. Pseudopolyps are seen, and tips of these polyps fuse to form mucosal bridges. Let me show you in the next slide. See, this picture is taken from Robbins, and you can see that there is a red granular mucosa of colon. Okay, then there is an abrupt transition between uninvolved and involved colon. Okay, and this is a picture showing pseudopolyps. Okay, these polyps. किसी ने नहीं बताया pseudopolyps. चलो होमवर्क है कर लेना. ठीक है, पढ़ लेना. This is the tips of these polyps fuse to form mucosal bridges, which is shown here. Okay, let's move ahead. Microscopic appearance. Inflammation is limited to mucosa and submucosa. There is crypt abscess, crypt distortion. This is a crypt. Sometimes you'll see the inflammatory infiltrate in this in the lumen, which is forming the ulcers, and you'll see the abscess formation and cryptitis here. Okay, this all inflammation and cryptitis you'll see. Okay, then pseudopyloric metaplasia. Pseudopyloric metaplasia is what is metaplasia? Anybody? So good. So, pseudopyloric metaplasia is seen in ulcerative colitis, but is most commonly associated with Crohn's. Okay, you will see in the subsequent slides. Good. At least somebody is awake. Change in epithelium. Good. Then submucosal fibrosis, mucosal atrophy, and distorted mucosal architecture is remain as residue of ill disease can be seen. Okay. Diagnosis is based on blood tests, tools, samples. Flexible sigmoidoscopy can be done. Colonoscopy is very commonly done. Okay. If you are not able to diagnose on the basis of routine investigations, you should take you should do special investigations done. Okay. Treatment is anti-inflammatory drugs like 5-aminosalicylates, sulfasalazine, mesalazine, dulcibazide, corticosteroids. Okay. Immune system suppressors like anti-TNF drugs like infliximab, adalimumab, etanercept, calcineurin inhibitors like cyclosporine and tofacitinib. It's a new drug given in cases of ulcerative colitis. Surgery you can do if there is diffuse involvement, the symptoms are not remitting, then you can do surgery also, proctocolectomy with ileoanal anastomosis or formation of ileal stone. Okay. Then complications, the perforated colon can lead to peritonitis, severe bleeding can be there, severe dehydration. Recurrence is very common in ulcerative, and toxic megacolon is, which you have seen in the previous slide. It can in where we were differentiating between the two between Crohn's and ulcerative, you were seeing toxic megacolon can be there in ulcerative more than Crohn's. Increased risk of colon cancer, also more than Crohn's. Increased risk of blood clots in arteries and veins. Cancer surveillance should be done every 1 or 2 years, beginning as early as 8 years after diagnosis, if the majority of colon is involved, or 15 years if only left side or right side of colon is involved. Then Crohn's disease, a few words about Crohn's. Okay. It basically involves any part of GIT, but most commonly it involves terminal ileum, ileocecal wall, and cecal. Skip lesions are more commonly seen in Crohn's and diffuse in ulcerative colitis. Strictures are formed because there is a transmural inflammation. So there is strictures because it is involving the whole of the wall of the colon. So strictures are basically more common in Crohn's disease. Earliest lesion is aphthous ulcer, which may progress and multiple lesions coalesce to form elongated serpentine ulcers. Cobblestone appearance, you'll see in the subsequent slides. Fissures, these are most commonly involved. Transmural, I have already told you. Clipping fat. Clipping fat is mesenteric adipose tissue extends over the serosal surface. This is cobblestone appearance. Again, there's thickening. Okay. There is thickening of the mucosa, transmural involvement with normal colon. This is a cobblestone appearance, and in the colon you can see similar finding. Okay, the one which is shown here, and the one these are the pictures of Crohn's. The involved and uninvolved colon. Involved and uninvolved mucosa, which is giving appearance like that of cobblestone. This is clipping fat, which is because the mesenteric fat is extending over the serosal aspect. Okay, so बाहर से तो serosa ही दिखता है ना colon का. On cutting open, you'll see the mucosa. Okay, so this fat is creeping over here, extending over here. Okay. Then cross appearance colonic Crohn's disease, the normal mucosa on either side of inflammatory strictures. So this is your stricture and the ileocecal region showing typical thickening of the wall with narrowing of the rim. So this is यहाँ पे थोड़ा सा narrowing of rim है, ठीक है? and it is transmural involvement is there, and this is showing structure. Okay. Microscopic appearance. Crypt abscess can be there, but more commonly seen in ulcerative. The best thing to diagnose is non-caseating granuloma, which is seen in Crohn's. Pseudopyloric metaplasia is more common than ulcerative colitis. It is more commonly seen in Crohn's. Penicillin metaplasia and pseudopyloric metaplasia is more commonly seen in Crohn's than ulcerative colitis. So this is granuloma. Previous picture was hazy, but this picture is quite clear. See, this is granuloma. Okay. Crypt abscess किसमें दिखता है? Ulcerative में. Okay. So these two are two differentiating features. Okay. Crypt abscess is more common. Cryptitis, crypt abscess is more common in ulcerative, and non-caseating granuloma is more common in Crohn's. Okay. And this is a picture taken from Robbins. Can you see repeated injury? Not very clearly seen, but there is crypt organization is distorted after repeated injury and regeneration. Okay. Proper crypt is not cannot be seen. Okay, पूरा distorted सा है. And this is a non-caseating granuloma. ठीक है. There is active ulcer is formed because ulcer is formed when there is a breach in epithelium. Okay, so all the inflammatory cells you will see in the lesion. Okay, so ulcers are formed, can be seen in Crohn's also. ठीक है. And there is a transmural involvement. Well, you're seeing all these granulomas. 1, 2, 3, 4, 5, 6. So many granulomas involving the whole of mucosa, submucosa. Okay. So transmural involvement with submucosal and serosal granulomas. Moving on to the next slide. Pseudopyloric metaplasia, it is basically an aberrant observation of antral type of glands in both body of stomach or in the intestine. So you are seeing antral type glands in the intestine. So this is pseudopyloric or a pyloric metaplasia. Okay, commonly associated with IBD, more commonly associated with Crohn's than ulcerative. Okay. So, pyloric gland metaplasia is a marker of chronic injury in the intestine. Ileal mucosa from a patient with Crohn's disease demonstrate chronic colitis with villous architectural distortion, basal lymphoplasmacytic infiltrate, and pyloric gland metaplasia. So, I think this picture is quite. See, this is duodenal mucosa, intestinal mucosa. You are seeing pyloric mucosa in the duodenal mucosa. Intestine is there and you are seeing the pyloric antral type of glands in the intestine. These are antral type of glands which you are seeing in the intestinal mucosa. Okay. So that is pseudopyloric or pyloric metaplasia. Next slide, Panel cell metaplasia. Panel cells, these are unique epithelial cells which are responsible for secreting antimicrobial alpha defensin peptides as well as enzymes such as lysosome, phospholipase A2, which keeps the intestinal crypts sterile. So main point is antimicrobial. They have granules. These are Panel cells. They contain granules and which are involved in which have antimicrobial properties. Okay, these are mostly located within the small bowel, distally only in pathological states. Okay, mostly involved in small bowel and distally when there is a pathological condition. Crypt-based columnar cells which are involved in crypt regeneration. Okay, so these are Panel cells which are normally seen in small bowel but can be seen in large bowel in cases of any pathological condition. And they have antimicrobial properties. So these are Panel cells. Okay, they are having granules See, these are more eosinophilic than the rest of these cells. Okay? And they contain planings which have antimicrobial properties. All the enzymes and peptides, they have antimicrobial action, which keeps the lining sterile. So, extraintestinal manifestations nearly similar to ulcerative pericholangitis or primary sclerosing cholangitis, sacroiliitis, or ankylosing spondylitis, migratory polyarthritis, erythema nodosum, cutaneous granulomas, uveitis. You all can see these conditions. These are associated with these IBDs. Treatment is with salicylates, immunosuppressors, corticosteroids, biological therapy such as anti-TNF antibodies. Thank you. Any questions? Let's see. Any questions? I know, more boring lecture. I can understand your conditions. Any question? No, मैं अभी लिख दो यार. चलो. Let's wait for 5 minutes. अगर कोई क्वेश्चन होता है तो बताना. So let's call it a day. So bye bye. Enjoy your day. काफी boring.